Thank you for the chairpersons also who will help with this, with moderating the session. I have to confess that I did already give them the questions that I would ask. So if you want to surprise them, you'll have to get up and ask questions. The first question is to Dr. Matthew Phillip, who is a gastroenterologist. And he is also has the distinction of having a normal BMI among most of us. So my question to Dr. Matthew Phillip is, what are the chances that you have fatty liver? Or the individual in front of you like me, when you look at me, are you likely to think that I've got fatty liver or not? And how would you make that assessment?
Actually, the question he has sent to me is that a person is sitting in front of you, and can you say that he has got fatty liver in Kerala? What he means is that no, everybody in Kerala has got fatty liver. That is what I think is the question. So I think there are actually no good studies in India, but there are certain studies saying that in Indian population around 10 to 32% will have NAFLD. And there is a study from Kerala too, and that is from Calicut Medical College. What they have done is they have looked at the patient bystanders, actually they found that around 27% has got fatty liver. But please note that this fatty liver as such, there can be, it's a spectrum, and NAFLD has got a spectrum of steatosis as well as steatohepatitis and then fibrosis, all these things, So the differentiation of all these things are different, the implications are different as well. And also by just looking at an ultrasound saying that a hypercoagulation will label it as a fatty liver, and there are three different radiologists will agree there are three different grades, and the grades also varies, and it depends upon the amount of fibrosis also differs. So just by seeing a fatty liver is not everything, because steatosis alone will have a different implication in prognosis, and NASH has got a different implication. So I think just by looking at a person, you cannot say that. And moreover, lean NASH, which I think you are going to ask me again about that because he asked you that, because lean NASH is also different. And Asian obesity is slightly different because it is not that just depend upon BMI alone, but you have got something called a triangle obesity or a central obesity or Asian phenotype obesity, all that's different. So I think it's slightly different to answer. And wherever actually you sit, you see a person in the hospital, it's different because you see a different group of people in the hospital. They are patients, or even the bystanders are got phenotypically, genotypically similar to the patient you are seeing. So it's different. So if you go to a common community and see a patient that is different, person that is different. So I think it all varies where actually you practice and different. If you are working
can I make a comment here?
Yeah, go ahead, Dr. Koshi.
10% of those with normal BMI, 10% of those with fatty liver have normal BMI. And if they have diabetes or lipidemia, then it may be 20% of those with normal BMI. Those with fatty liver have normal BMI.
When we were in medical school, a safe answer for most questions was the number 10. So I remember a rheumatologist asking one of our clinics, what is the incidence of rheumatoid arthritis? And one of in England, because those days, all the statistics were from England. And he said, for want of anything better, he said 10%. And the guy said, they are not a nation of cripples. So here we have, a nation of fatty liver, I think, because we are all over about 20%, 10%. These are the numbers I'm hearing. So and I'm also hearing that lean NASH. So the question is, what is the evidence that losing weight will get rid of the fatty liver? And if you all are using drugs to help these people get rid of the fatty liver, what is it that you use?
Now, what is the BMI you are setting? You should have a level, say that above 25 or below. In Asia, in Western standard is considered to be 25, but in Asia it is considered to be 23. So a person coming to you with 30, still according to us he is overweight. And a person in 25, according to Asian standard, is overweight. So even if in those patients with lean NASH, it has got so many factors as we looked at, whether he is a diabetic, whether he has got metabolic syndrome. All these are important in planning things for him. and what are the other cofactors like alcohol, because in Kerala I don't think that you cannot see, probably you may not be able to see a pure NASH except in males. Maybe they have got both combined alcohol and NASH, and the quantification of alcohol is quite difficult here, and what is written in the Western literature may not be true for Indians or especially Keralites, and the living style is different. So all these factors come into it. It's actually a very complex thing, it's very difficult to answer these questions. But I think there is a role for, even if in so-called lean NASH, for exercise and diet. But diet can really modify them. And exercise actually, for every person, exercise is good. So actually there may be a role for that. And the only intervention which can...
What about the drugs?
No, the only intervention which have really shown benefit in NAFLD is actually exercise and the diet. And some reduction of weight, even if it is 5% or 10%, there is a significant reduction in the liver histology, in steatosis and inflammation. Fibrosis may be different studies maybe, but that is the only intervention. Regarding drugs, you asked me, there are an array of drugs. And my practice is that when I see a patient with fatty liver, I just ask about the history, family history, alcohol history, whether he is a diabetic, whether he belongs to a group of metabolic syndrome patient. So that is how I manage. And if there is alcohol, I ask him to stop 100% alcohol. There is no question, I don't allow alcohol in these patients, because you have got one illness which can aggravate if you take alcohol more. And regarding drugs, the commonest drug I use is vitamin E.
Vitamin E?
I give around 800 milligram for these patients, and other drugs I don't generally use. There are array of drugs and anti-diabetic drugs like metformin, but there is no real evidence actually it really improves in these patients. And pioglitazone, people are worried about the side effects, so people started using less in number now. Orlistat, it is not going to help much. And other drugs, UDC, a very commonly used drug. In some patients, actually, you try when the enzymes are quite high to try these patients. My policy is wait for 6 months with exercise and diet and vitamin E, and there is no change in enzymes. I ask him to undergo liver biopsy. This is what I practice.
Dr. Koshi wants to add.
There's a paper in Gastroentrology this year, which for the first time has studied the effect of exercise intervention on fat measured by MR, both by in-phase, out-phase, as well as by spectroscopy. And what they did is a 2-month, they had different grades of exercise, 2 months intervention. So low-grade exercise for a short period to high-grade exercise for a long period. And all those who did exercise, the fat came down within 2 months. So it has been documented now for the first time that actually liver fat comes down with exercise as short as 2 months, and even low grade, some exercise is good, more exercise has other additional benefits apart from lowering liver fat.
And most of these patients will be taking some drugs. In India, especially in Kerala, everybody takes Live 52 along with their evening peg of alcohol.
Can I ask Dr. Koshi, there is actually a study from Lucknow, SGPGI, in the past. Actually, they have looked at in NAFLD patients, exercise and dietary modification, whether it reduces. Actually, they looked mainly at enzymes, and enzymes actually came down. And ultrasound actually takes time for, and the only thing that we have to see that this is sustained, this has to be for a longer period. And Live 52, I'm not an authority to talk about that, but I think there is no role for any of these medications, And I have told you many medications, and actually ASLD does not recommend any of these medicines. They have written that glitazones can be, pioglitazone can be tried in some patients, but the long-term side effects actually prevents them. And especially when there is any cardiac illness, you should not use this. And that diabetic patients can have a silent cardiac illness also. So we are not really justified in using these drugs unless we get an evidence for that. But new drugs are coming up, and there is actually new drugs. Recently there was a gastroenterology article actually showed that benefits of these newer UDCA varieties, actually they are trying to do. And I think the major intervention is exercise and diet. And for diabetic patients, good control. Please note that vitamin E is not recommended for diabetic patients because there is no evidence. So vitamin E, why it is recommended is because it's the NAFLD is the oxidative stress, and when you actually use vitamin E, it can actually act as free radical scavengers and do some benefit. There is some fear of vitamin E because long-term use can produce prostate cancer. There is only one report about that, and one study has shown that if you use in patients, generally overall mortality can come down, but that paper is also not supported. So we don't know, but that is the only drug which is commonly used. Vitamin E.
I would use drugs only when there is evidence of steatohepatitis, like metformin or vitamin E. But it's a simple fat. Obviously, you do exercise either way, exercise. But if it's steatohepatitis, then I will use drugs. Would you?
Yeah, all the studies on drugs have been used in steatohepatitis. They have not been used in simple fatty liver.
No, sir, the reason is steatosis actually does not increase any liver-related mortality. There is no, just steatosis, it does not increase any liver-related mortality. Actually, the mortality occurs because of non-liver-related mortality, because of obesity-related cardiac illness and all those things. Only if you have evidence of NASH, when there is steatohepatitis or evidence of fibrosis, then actually the liver-related morbidity and mortality increases.
So changing gears a little bit here and addressing our surgeons, and let me ask Dinesh this first question, and I'm sure Shabir Ali will also add to this. When you have a live donor, we'll do live donors as well as cadaver donors. When you have a live donor, tell us what you do basically to assess these patients for suitability to donate. In other words, do you do a battery of tests on everybody? Do you have some sort of a screening method before you subject them to all the tests that we spoke about, that Dr. Venkatesh also spoke about? Tell us, what do you do when you see a live donor before you for the first time?
Thank you, sir. So when you see when a donor comes up, we do a screening test. So a liver test is mandatory, and if the enzymes are normal, then we do an unenhanced CT scan. So we look at the attenuation of the vessels. If it's a low attenuating vessel, which can be traced up to the periphery, so there's a grading, and the L minus S is a positive value, we would accept this donor. What we are worried is an isoattenuating. On an unenhanced scan, the vessels are not seen. It's isoattenuating with the parenchyma, or the attenuation of the vessels is more. Grade 4, grade 5, this we are worried. A grade 5 visual assessment, we would refuse the donor. In a grade 4, if the liver tests are normal, we would biopsy this liver. And the liver biopsy, if it is showing 15 to 20% steatosis, no inflammation, no features of lobular inflammation or ballooning degeneration, then this patient, if he is very motivated, we would counsel him, but if he is very motivated to donate, then we would suggest a diet. The dietary department gives a written down diet and an exercise plan for 6 weeks, and the donors are re-evaluated.
So we want to add to that?
Yeah, we also follow almost same protocol, but usually we get a baseline. Can I have my slide? Baseline liver function test, lipid profile, and we have a very low threshold for going for biopsy. We see all these things together initially, this BMI, age, liver attenuation index. We actually go with a cutoff values for liver attenuation index rather than looking at subjective things. And if it is less than 5, we always go for a biopsy, and less than -5, we won't even do biopsy. Elevated liver enzymes, lipid profile, and a family history of NASH, especially the recipient is having a suspected NASH CLD, and a relative other indications like a marginal GRWR and a sick recipient where you want to get a perfect liver in the living donor scenario, we go for a biopsy. And we accept up to 20%, 15-20%, considering other factors also, and the recipient factors. And if they are showing a marginal liver and a liver fat more than 20% or inflammation, we do go for a weight reduction, and we get a dietary consultation and physiotherapist's opinion for a graded weight reduction measures, maintaining the essential amino acids and fat. Then a weight reduction of up to 0.5 to 1 kg we recommend. And we do a repeat liver attenuation index after 6 to 8 weeks and proceed with biopsy if it is acceptable. We have only very small experience in this. We tried 5 in such donors. They are prospective donors who found to have a fat beyond 20%. And we had 2 males and 3 females. They had a steatosis documented. We usually get 2 pathologists' opinion on this, 30-40% in all. And most had an FLD score around 4-5. And BMI, we had 3 of them with BMI more than 28, but usually up to 40, and 2 of them with less than 25. Indeed, one had less than 25 BMI, but had a dyslipidemia. And we could achieve weight reduction in more than 4 out of 5 patients. And one patient who had significant inflammation also, he also got an improvement in his liver enzymes. And we did biopsy in 4 of them. It showed an improvement to less than 10% fat in 3 of them. And only one actually led on to transplant. The other 2, one recipient died in that meantime, and other got a disease organ in the waiting period. And this patient, an FLD score came down to 1. Came down to 1. This was the pre-exercise in May 2013, and after 4 months, it came down to less than 10%. And this patient eventually led on to successful donation with a peak bilirubin in this donor was less than 2.5. And the recipient also had a good outcome.
Excellent. Any questions on that? Go ahead, Rajshekhar.
Question to Dr. Shabir. I disagree with your opinion about one with the inflammation. Do you still consider them as a donor?
No, that patient, actually we actually recommended him exercise and diet. That recipient got a disease donor eventually.
Yeah, but
he had an improvement in enzymes in exercise. We haven't done a repeat biopsy on him. We haven't considered him later.
So, Dr. Venkatesh, you have any comment about our, I think what they've talked about is sort of the protocol followed everywhere in live donor centers in India.
Well, I think at the clinic we do it differently. We do not use the CT at all. CT is mainly used as a CT angiography for evaluation of the vessels and also for volumetry for the livers and other things we do. But with regards to fat, the cutoff is 10%. They don't accept anybody more than 10%. And then we also use MRI for quantification to do it. Only if things are not borderline or not falling in places, that's when we go for biopsy. And especially if the donors are scarce and they need a donor, and it's turns out to be a perfect donor in any other aspects. So we don't use CT at all, so it's a different practice altogether.
Okay, so we will have obviously cost implications of each of these philosophies. But changing gears again, I'm going on to the cadaver donors, where probably you won't have the opportunity to do either a CT scan or an MRI scan, and they're always going to be suboptimally evaluated. So my question to Dinesh is, what are the situations in which you will walk away from the donor?
A donor who is poorly
where you suspect that fat will be enough for you not to proceed any further?
Well, based on just a fatty liver, I'm not sure whether I'll walk away. But if a donor has got multiple issues, like if it's a very marginal donor on multiple counts, and the patient is having severe fatty liver, then I think I would refrain. As regards assessment of fat, as a team, we rely on the surgeon's visual inspection and palpation. We do not routinely do a biopsy, but if there are multiple risk factors in the donor and a fatty liver, on inspection you think it's a severe fatty liver, then I would not accept this donor.
Okay, go ahead, Shabir, you want to add to that?
Yeah, we also usually follow almost the same pattern only, but we have got a low threshold for biopsy and frozen, especially when the donor is beyond 55, we have a dyslipidemia or a hypothyroidism or diabetes history, or the body mass index is more than 28 or 30, and other poorly maintained donor or unstable donor, and all these things we go for a biopsy and frozen section. And we accept up to 50-60%, but sometimes we may have to change the recipient. A sick recipient, we may have to come down to a low MELD recipient or after an explained risk. And we won't take with moderate to severe inflammation or necrosis coagulative necrosis more than 10%.
It's very hard to get a BMI in a cadaver donor. Do you have any other metric?
Yeah, hip-waist ratio, we can see the hip-waist ratio also, and some abdominal obesity. And we have a low threshold for frozen. I think nearly 80% will eventually go for a biopsy.
What about the ultrasounds? Do you use them? We've got some data from the Hong Kong group where they can correlate the ultrasound findings with fat in the liver by other methods.
We do in in-house donors. We have tried ultrasound. Sometimes we can avoid these logistic issues of calling the recipient and all those things when it is severely fatty. But most of the time we will go for a try and we'll do a biopsy and decide. Can I have?
Go ahead.
Slides, please. We have accepted up to 50%. I think liver feel and appearance do we consider, but most of the time we go for a biopsy. And this is the one, I think, in our small experience, we have the worst one we have accepted. There's around 50-60% fat for a 54-year-old donor, female donor, died of CVA, but had no inflammation or fibrosis. And this one we had to give to a 30 male patient, and the patient had an enzyme, eventually post-op had an enzymes around 2,800 to 3,000, but without much clinical implication except for the ascites, which took some 4 weeks to resolve. Other things were all okay. And this is the one just 2 weeks back. This is the only donor we have rejected so far. This was a 72-year-old, multiple other risk factors were there. It's a 70-plus donor, 60-plus macro-steatosis, and even the micro were bigger nodules, bigger vacuoles which are displacing the nucleus, had significant inflammation, some stage 2-3 fibrosis. This is the only one liver which we have rejected so far.
When I was working in the US, I could never get a pathologist to read a frozen section on a cadaver. They won't do it. They'll just flatly refuse to do it. It's easy to quote the legal implications of making an opinion like that, but to me it looked like most of them were just not familiar with doing frozen section livers. And also there was a concern about the artifact changes which you get in a frozen. So how do you, now these were they frozens that you just showed us?
These were frozens only.
So the question to me that I have for you is, how much of that 50% was, in your estimation, artifactual? Are you convinced that it really was 50%?
I think the pathologists, the issue is you have to, what we learned is you have to persist with 1 or 2 persons who are used to it and with some experience in it. And more than for the artifact issue, what we found is more than the pathologist is the technician that matters. We had issue when the usual technician was not available. It's basically they should have some good experience in the liver frozen, where how to slice it, the slice thickness, and sometimes you can get artifact when the donor is in another hospital. You have to bring it with a time more than 30 minutes and all. Then you will get this autolysis and artifact. Otherwise, if the technician is good, he has some experience. He knows each liver, how to slice, how much thickness to slice. And it's more than on the pathologist, I think it's the technician that matters.
We have just a minute left. Any comments on that from our pathologists, or you want to just let that pass?
Yeah, Philip, I just want to ask.
Just let push back.
Madam. Sorry.
When we get a biopsy, if the fat is below 15%, we just do an eyeball rolling movement and give you the diagnosis. But a fat between 25 and 35, it's very difficult. We count the actual fat vacuoles and give a percentage.
Madam, fibrosis, how confidently you can see in frozen section?
If there is fibrosis, we can see it in the frozen section.
No, don't you want to comment between frozen section and a rapid formalin fix? I mean,
there is a difference between the frozen section. That is what I am saying. The 25 to 35%.
You will want a formalin fixed.
Yes. And another thing, if you send 2 biopsies, I have always asked Matthew to send us one in formalin also to see the permanent. There is a difference between the frozen section and the tissue sent in formalin.
So whenever a biopsy is done, you want frozen section and formalin fixed.
If it is
you
possible,
want both.
Yes.
Matthew,
I'm seeing so many surgeons here. I just want to ask, any surgeon doing bariatric surgery for NAFLD here? Dr. Sudhir, tell me your experience, just on brief.
Yeah, we have done, actually we were doing ultrasound and as well as per operative liver biopsies in fatty patients, and majority of them, around 50% of them were fatty liver. And after 6 months, we were again doing, once they had a weight loss, we again did a biopsy. And almost all of them, except very few, 1 or 2, all of them were completely, the fatty liver was completely subsided in them.
I told you, asked is that it's an emerging technique of bariatric surgery. Actually, ASLD does not recommend to do that, but they say there is no contraindication to. If somebody wants to do it for NAFLD, there is nothing contraindicates that. But not for cirrhosis anymore. If they develop NAFLD-induced cirrhosis, they don't recommend that.
If there are any other burning questions from the audience, we'll take them now, or we're over with our time. We're over our limit. Thank you to all of you on the panel and the chairpersons for a very informative session. Thank you.